in case we need to use it. Okay, meeting's now live.
Right, thank you very much, and apologies for the late start to the meeting. Technical issues. Anyway, good afternoon and welcome to the Portsmouth CCG Governing Board meeting in public. I'm Elizabeth Fellows, GP and Chair of the Governing Board. We're meeting virtually in response to the limitations placed on governance by the COVID-19 pandemic. Members of the public have been invited to view this meeting via a link available from the CCG website. Papers for the meeting are also available via the website. Today's meeting is being recorded so that in an event of failure of technology, it may continue and will be uploaded onto the CCG website as soon as possible. Bookmarks have been added to your pack of papers in order to identify the agenda items. Members are asked to keep your cameras on where possible and mute your microphones unless you're called to speak. Please only use the raised hands or chat functions to indicate that you wish to speak, as any typed comments can't be viewed by the members of the public. So no side conversations, please, in that chat bar. So just like to go round, we'll go down my list. If everyone can say their full name and their title. So Maggie.
Thank you very much. I'm Maggie McIsaac. I'm Accountable Officer.
Helen.
Thank you, Elizabeth. I'm Helen Atkinson and I'm the Director of Public Health for Portsmouth.
Karen.
Hi, I'm Karen Atkinson, the Governing Board Registered Nurse.
Linda.
Hi, I'm Dr. Linda Colley, GP and Clinical Leader for Health and Care Portsmouth.
Margaret.
Hello, I'm Margaret Geary, lay member for Portsmouth CCG.
And welcome to Sally.
Good afternoon, everyone. I'm Sally Hodges and I'm the Interim Director of Children's Services in Portsmouth Council. Nice to meet you all.
And it's welcome to your first meeting with us. Carsten.
My name is Carsten Schaffer. I'm a GP and one of the clinical execs at Portsmouth CCG.
Graham.
Hi, good afternoon, everyone. I'm Graham Love and I'm a lay member.
Nick.
Hi, I'm Nick Moore. I'm a GP, clinical exec on Portsmouth CCG.
Jackie.
Hello, I'm Jackie Powell, lay member.
Simon.
Hello, I'm Simon Simonian. I'm a GP and also one of the clinical execs here in Portsmouth.
Michelle.
Hi, Michelle Spanley, Chief Finance Officer.
Tawinda.
Hi, I'm Tawinda Uppal. I am Secondary Care Consultant.
David.
Hello, David Williams, Chief Executive, Portsmouth City Council.
Joe.
Hi, I'm Jo York, Managing Director, Health and Care Portsmouth.
Lovely. And then we've got some people in attendance, many of whom are here already. So if we can just run through those. There's Bernie.
Hi, Bernie Allen, Deputy Director of Planning and Analytics.
Jane. Where would we be without Jane?
Jane Collis, Business Services, taking the minutes.
Justina.
Good afternoon, Justina Jeffs, Head of Governance.
Tina.
Hi, Tina Scarborough, Director of Quality and Safeguarding.
Thank you. And then I believe later on we'll be joined by Sarah Shaw as well. So we'll introduce her when she comes. So we've got a few announcements, I think would be the phrase to start the meeting off. So we'll start with some really good news, which is congratulations to Maggie McIsaac, who has been confirmed as our Chief Exec Designate for the ICS. So congratulations, Maggie. It's really good that you're going to be staying around with us.
Thank you.
Thank you. And then also we've got congratulations to Nick Moore on his new position with Health Education England for GP training. And but that's sad because you'll be leaving us, so we'll certainly miss you. But training up more GPs will be invaluable. So good luck in your new work. Thank you
Thanks
very
for that,
much.
Elizabeth. Thank you.
We've also got some apologies for this meeting. One of them is Dave Scarborough. Unfortunately, Dave has felt he's needed to step down from his role as the practice manager representative for the city in light of the GP and primary care pressures, because he's not only a practice manager, but he's also a business manager for a PCN, and he's felt the role within the CCG is a step too far at this time. So we have sadly let him go, and he will no longer be attending any of our meetings. And I wish to pass on our very grateful thanks for all his work over the last 3 and a bit years with the CCG. He's been a great asset to us, and will be greatly missed. We also have apologies from Andy Sylvester, who isn't leaving us, but is just not able to come to this meeting. And I think that otherwise is everyone else is here. So let me just double check. Yep, that's good. Right, so moving on to our register and declarations of interest. We've got the register in the papers. We're being asked to note it and declare any actual, possible or perceived conflicts against the agenda items. Equally, has anyone got anything to change? Someone's got their hand up already and I'm in the wrong bit. Bear with me. IT skills. Simon.
Sorry, that's me. Just to say I've updated the register because of my, I've started working as a salaried doctor at Lake Road Surgery and also locum at Shipka. So I've sent that in, but it's not on here just yet. Lovely,
thank you. Doesn't change your position for any of the papers today, though, I don't believe, does it?
I don't think so.
No. Thank you very much. Anyone got anything else? This is truly a living document. We change it every meeting, so let's keep up the good work. Thank you very much. Moving swiftly on to item 3, minutes and actions of the previous meeting. Being asked to approve these minutes. Have people got any comments or questions about them first? Any corrections? Jackie?
Oh yeah, I think there's a couple of corrections and I had a quick query. So on the last page, this might be for Jane's benefit, 3rd paragraph down, so page 11, 3rd paragraph. It says Margaret Gary commented that Age UK have a veterans, and I think service needs to be added in there rather than we have a tame veteran. You see what I mean?
Right, sorry, I've lost you. What?
That's okay. So page 11, 3rd paragraph down, starting with Margaret. Margaret commented that Age UK have a veterans service.
Okay, thank you.
And then the sentence underneath that, I think a bit of clarity would help. So say, Jackie Powell commented, Portsmouth have a affordable counselling service, which may be an option. You all right there?
Okay.
Yeah, you got that. And then a very quick query, it might come up later on, but on page 7, we're talking about the emergency department and the capital build. And what's mentioned is that there's going to be a new modular build with a 72-bed ward. So I just wanted clarification, was that part of ED or was that part of another capital project?
Jo, can you just clarify what the builds are?
So that the modular bit, it's a modular build of 2 new ward spaces that is allowing greater move and creation of a medical village to support same-day emergency care access. So the new modular build is 2 additional wards, but that allows some moves around the ED and ambulatory medicine department of the hospital. And they've also opened an emergency, I always get this wrong, emergency care centre, some additional space in ED. But it's the modular build is the 2 wards.
Oh, that's great. And And it's on track. I'm hoping it's
Yes.
due to be open. Lovely, that was it.
In January,
you.
yeah.
In January, thank you.
Okay, thank you. So subject to those minor changes that Jackie has proposed, are people happy to accept these minutes? Nods all round. Good, lovely, thank you very much. 3B, we've got the summary of actions. So register and declarations of interest being updated, minutes adjusted, and Justina's got the development session discussion sorted. People happy with all of those? Any questions on that? No, lovely. So moving very swiftly on to item 4, we've got over to Helen for an update on the state of the nation, or the state of the city anyway. Thank you, Helen.
Thank you, Elizabeth. I'll just share some slides. You bear with me. It's just loading now, and I'll basically cover the normal set of slides which give us the current infection rates across the city, but across Hampshire and Isle of Wight as well. It's just coming now, as well as the national comparators, an update by age group. Here they come. And also the vaccination uptake rates, and then hospitalisations. So if we quickly start with our infection rates for Portsmouth, you'll see there that we have had 809 new infections in Portsmouth of COVID-19 in the last 7 days, which takes us up to 31,389 people with at least one positive COVID case since the beginning of the pandemic. And when we look across Hampshire and Isle of Wight at our spark lines, just to give the overall impression, we've obviously been in the third wave, which I know you all know, but we've been coming down in terms of the infection rates now. But you'll now see that each of the areas, including Portsmouth, are now uplifting again. So we were getting to quite high infection rates just before half term. And there's no doubt, because quite a lot, which you'll see when I show you the age distribution of infection rates, a lot of cases have been in our school age population in the community. But what we have seen is that reducing with the half-term holiday, possibly more to do with the fact that there were less children and young people in that period testing, than actually that there was a reduction in infection. But now what we're starting to see is that increasing again. So all of those spark lines show you that we are starting to move to an increase again. And when we look at the national comparators, just to say that they have changed the key. They tend to, at UK Health Security Agency, change their key. So as the infection rates go up and then they come down, you see different levels of the red. But you'll see here that a couple of weeks ago it was mainly in the southwest of England, but we've now got red patches and deep red patches across the whole country. But you'll see that Hampshire and the Isle of Wight, including Portsmouth and Southampton, are mainly in the orange there. So the England current rate per 100,000 is 364.2, and the southeast is at 402, and we're pretty within that in terms of Hampshire and the Isle of Wight there. So Portsmouth infection rate per 100,000 is at 376.8, which is a reduction. The Isle of Wight at 402 per 100,000, which is exactly the same, actually, interesting, as the southeast. And Southampton at 397.4 and Hampshire at 430.3. It's important to point out that Hampshire have got quite a lot of variation in infection rates currently. So Gosport, as an example, which is obviously a near neighbour to us, have got this week, they have had the highest, but they're the second highest lower tier local authority in the country. So we are still seeing quite high rates within Hampshire. And there are a couple of comparators there, Bournemouth, Christchurch and Poole in the southwest there and North Tyneside. The southwest is still recovering from the episode which was in the media of the laboratory where there were issues with false negatives, and of course that meant that there were people with COVID that didn't think they had COVID, obviously still in the community spreading. So that caused quite a high increase in infections in the southwest of England, but that gives you the kind of comparators we're seeing now. And although it's looking pretty good in terms of those some of those percentage changes in the last 7 days, it's clear, and we are starting to see a number of outbreaks in schools since half term has gone back. And I'm sure many of you as clinical leads will be starting to see quite a lot of activity around COVID in young people again in your surgeries as GPs. So what we're seeing, and there's usually a bit of a time lag, because obviously children in schools start to the spread in the school, that goes back into the family, and then there's spread across the community. So we are starting to see increases again. And just to give you an example of that, so this is all age band comparators, and you'll see here that rates remain the highest among the 0 to 14-year-olds, so the school-age children, over the recent days, but rates are fluctuating in the other age groups also there. So you'll start to see that there are increases there, particularly in our 45 to 59-year-olds and our 30 to 40-year-olds. So if we just take that data and then look at school-age children, you will see there that rates have risen slightly in the last week again since half term in both primary and secondary ages, but it's not yet clear if this is a sustained trend. But I think we're starting to see that it is likely to be a sustained trend going up, because we've started to see those outbreaks in schools. But it is in school age children. It doesn't seem to be impacting so much on the either the younger age groups so much, or the teenagers and slightly older, 17 to 21-year-olds. And I suspect we hopefully see that as the success of the vaccination programme, because obviously that's the age group, particularly the 17 to 21-year-olds will have had the vaccine longer, but hopefully the schools vaccination programme, which has been very successful in Portsmouth, will have that impact. And then if we look at the vaccination uptake rates, we're slowly improving those. So first dose we're now at 77.8%, and second dose now has tipped over 70%. Important to note, of course, that currently this is from total percentage of people aged 12 and over. So our 12 to 15-year-olds are only getting one vaccine currently. So it's important to note that in terms of the second dose, which still includes them in terms of the population groups. And quickly, then, if we quickly then look at the impact that has then in the NHS, we are starting to see, we know obviously, and there will be that the NHS is under significant pressure currently, not only and actually predominantly non-COVID, but we are starting to see a slight increase in patients admitted as well into hospital and those on ventilation or in ventilation beds in ITU. So that is beginning to increase, although it very, very slowly. And then if we look at our deaths, there have been 4 deaths in the last 7 days, 5 deaths in the last 17 days in Portsmouth, and 393 deaths in total since the beginning. But importantly, when we actually look at that in terms of our average deaths expected per year, we still see that in Portsmouth that is still slightly, it's not gone over, which is actually interestingly different from the national picture, where we are seeing in some areas deaths over the average you'd expect by looking at the previous 5 years and taking that average. So that's what we call excess deaths. So Portsmouth is still just under, but we know nationally that there are areas where they're seeing excess deaths over what would be expected. And that's it in terms of the presentation, and I'll stop sharing. Elizabeth.
Excuse me for coughing. I've had a negative PCR test today, so it's not COVID, even though it's irritating. Questions, Maggie?
Thank you, and thank you, Helen. Always incredibly comprehensive. I guess could you just do that summary for us, which is what the person in the street says. So is it getting better or worse? Are we going to have another lockdown?
Those are really, really difficult questions, but I will do my best, Maggie. So I would, and always remembering that public health are always slightly less than optimistic. Most things we are very optimistic about, but we're always slightly nervous when we talk about infectious disease. So I think that we are in a place on the third wave that we are going to see cases increase now between, before Christmas and into the new year. What we are seeing is predominantly, and actually each wave has been different, hasn't it? But this last wave, the third wave, is very much about schools. And I think what we are seeing is an increase, a continued increase, because I would say it's a continued increase. It started obviously before the half-term holiday, where we are seeing transmission in schools, although schools are working incredibly hard to reduce the risk. That transmission, of course, then goes into homes. So what we are also seeing is transmission, and there's usually a slight timeline of cases that then will increase across the other age groups. The positive of that, though, is because of the success and continued success of the vaccination programme, we are hoping that those cases will be less serious and not lead to hospital admissions and deaths, which is pretty much the picture that we are seeing, albeit that the NHS is under severe pressure for obvious reasons, because we have been in in and out of lockdown for the last 20 months. People haven't been mixing, they now are. So there's that increase in other viruses. So we are seeing, I didn't put a slide in today, but we are seeing increases in other winter viruses, and earlier than we would normally see necessarily, because of course people weren't spending so much time together. So people's immune system maybe not as strong as it was in previous years, and also people are now mixing more. So we are seeing an increase, and I don't think we've completely peaked on wave 3, I'm afraid. I think that's ahead of us still, and that's what the Southeast, what the modelling that we've done in Hampshire and Isle of Wight is still saying, albeit with a not as bigger impact as the previous waves we've seen. So trying to be optimistic, I think it's better than previous waves, but I don't think we're over the third wave. And I would like to use this opportunity, as I always would, to encourage people to take up the vaccination offer. And I know everybody on this call will have done so, but we've still got work to do done. And of course, we've had the announcements this week, and I don't want to steal anybody else's thunder, but for the booster coming down to the 40-year-olds now and over, and also second vaccine for our 16 and 17-year-olds. So really encouraging everyone to get the booster. And there's a big media campaign, NHS media campaign starting this week. And also, obviously, it's difficult for me because it's not necessarily what we're hearing nationally, but I would still be encouraging people to do all of the other measures, which many of us still are. And obviously that includes wearing face coverings, regular asymptomatic testing, and washing hands, and all of the catch it, bin it, kill it campaigns. So although not awful, I think we're not over the pandemic yet, if that's helpful.
Really helpful to say it like that. Thank you, Helen.
Thank you. And Helen, what about flu this winter? We've been hearing that started early. Have we got any statistics on that yet?
Well, yes. So I think what we are at the stage of, and obviously you'll know what's coming in terms of what you're seeing as GPs. However, we're not necessarily seeing a huge increase in influenza yet. We have had a couple of outbreaks. We had one in one of our care homes recently, and we are starting to see a slight increase in positive influenza cases admitted to hospital. But I think we're at the beginning of that. We are expecting it to be a bad influenza season, flu season, because that's what's happened in the southern hemisphere, and what happens there tends to come here. And and two, again, for the same reasons as COVID last year, because we had hardly any flu. I mean, you'll remember we had very little other winter viruses and hardly any flu, because basically people were on lockdown and not seeing each other. So we expect it to be high. I think that we're starting to see that increase in some of the numbers, not in necessarily all. We had quite a big rise in RSV, but that seems to have plateaued now. But I do think we will start to see, and also the other winter viruses. So again, that's the other message, of course, isn't it? Flu vaccine. Now, the other side of that is that we are seeing really good uptake in flu vaccination, as you know, and we did last year as well. So really encouraging people to have their flu vaccination as well, which I know you're all doing.
Lovely, thank you. And that's encouraging to know people are coming up for their vaccinations. That's great. We've got Karen.
Yeah, just a question of out of interest, really. Helen, do you have any insight on why London, that's highly populated, has got low infection rates, really low infection rates at the moment?
Yes, there is some hypotheses. I've actually just been speaking to one of the DPHs from London, and I asked him the same question because we've been looking at it. We think that some of that is because you'll remember that they got hit really hard by when Delta arrived, and then they've also, so they got really hit hard. And there is some view that because they had such high numbers that there is what's called sometimes the virus has burnt out, or that there is quite high now immunity in that population. They're obviously a city area, highly populated and quite young population as well. So there is a view that it's because they have actually, got quite a lot of immunity because so many people have had it in London. They don't, and they have also looked at the testing. The testing numbers have remained high, so it's not because people just aren't getting tested, because they have the same testing numbers and also positivity in that testing. So I think it's for that reason, and that could also, obviously, that could be why, at some point, hopefully not too far, we will be coming down out of the third peak as well.
Yeah, it's certainly not because they're wearing masks and that, and distancing in London was up there relatively recently. It was interesting. Right, any more questions for Helen? Thank you very much, Helen. It's a very useful and informative report, and it's encouraging to know that we're cracking on with vaccinations across the city so well. So thank you very much. I'm on mute, wrong thing. So item 5, we've got Joe's coming in with the executive report.
Thank you, Elizabeth. And the thing I really wanted to highlight on the report was the work that we're doing as a Portsmouth South East Hampshire system, but also as part of the Hampshire and Isle of Wight Integrated Care System, to support and to reduce ambulance handover delays at Portsmouth Hospitals Trust. As Helen's indicated, we, increasing rates of COVID and some increases of those admissions in the hospital, the NHS is under severe pressure, and we are seeing that in handover delays at the acute trust that have reached really sort of really difficult levels, and all partners are working together really hard to renew our focus and accelerate all schemes to ensure that we are seeing those ambulance handover delays coming down as quickly as we possibly can. There is a clear plan that we've been working on with all partners that recognises the complexity of some of the issues and long-standing nature of the issues that face Portsmouth Hospitals Trust, and particularly around their occupancy, and recognise that the new modular build will increase bed capacity at the trust, but is not able to open until January. But a lot of work is being done to accelerate things in preparation for that, in terms of that enables the move towards the medical village, and creating additional support to the emergency department and accelerating provision of what they call same-day emergency care to avoid admissions. In addition, as part of that, there is increasing, the trust are also looking to increase workforce around senior decision makers in the front door as well. So there's some action specifically for the trust, but as we know, this isn't just a single organisation issue. It affects all of us, and all partners can and are playing their part. So we're also looking with primary care, looking at what we can do to strengthen the clinical assessment services, to divert ambulances and reduce conveyances to ED. So lots of work going on with Portsmouth Primary Care Alliance and our community colleagues in Solent and their equivalents in South East Hampshire as well, looking at what we can do once in terms of a community and acute same-day emergency care unit for frail elderly patients, so that again we can avoid those admissions where possible, and also working really hard with local authority partners both in Hampshire and Portsmouth to increase capacity out of hospital and to look at how we can increase the number of discharges on a daily basis. So there's a significant piece of work going on with all partners. Everybody's working very hard to accelerate current plans and really resolve that position as quickly as we can, recognising that we're heading into winter and a more difficult period as well. There are some financial implications of that, although we've been working very hard with NHS England, both regionally and nationally, but all organisations have recognised that we need to take a risk and cannot wait for funding. So therefore the plans where it requires acceleration and increased workforce, we've gone at risk to ensure that can be put in place as quickly as possible, and obviously we can pick that up a bit more in the finance section when we get to it. But that was really what I wanted to highlight and bring to the board's attention, sort of serious nature of this and how hard everyone is working together to support that. And Maggie may want to add to that as well before we take any questions. Thank you.
Yeah, thank you, Joan, for all of that. I mean, I think there is no question that all organisations in the Portsmouth and South East system are working really hard with a really clear plan. We've gone ahead at risk on funding things, so huge amount of work, and a bit like we had in the peaks of COVID, starting to get people redeployed back onto this agenda from other things. So, you know, it is a huge thank you to everybody in all parts of our NHS social care and public services for really focusing on this. You know, no place is an island, and such are the pressures, particularly over the last 2-3 weeks. We've started to see the need for mutual aid across the wider Hampshire and Isle of Wight and possibly beyond. And that's always very tricky when you're starting to talk about how can people at our borders help. But we have reached that kind of situation. So in recognition of that, both Linda, certainly David and I have been working with leaders across Hampshire and Isle of Wight, trying to make sure that everybody from a leadership perspective is doing everything they can, even in the organisations that are further away from Portsmouth. And this coming Friday, we're going to bring everybody together again, recognising we've all been testing our plans in a way, you know, further refining and testing our plans. And we're bringing people together across our geography, all the leaders, police, fire, local authorities, NHS, to really say, and what else can we do, and how can we help each other more in this is very, very pressured situation. And as Helen said, you know, we're now experiencing the levels of pressure that you would commonly find at the very, very peak of winter, and it's still only November. So I think, hence my question to Helen, to say a bit more, you know, faced with COVID might get a bit worse, and certainly normal flu and viruses might get a bit worse. We are going to have to do a bit more, and that's what Friday is about. But that's not because people aren't doing things. People are working incredibly hard. We've got to make sure that the level of risk and the level of acceleration of the plans is the same in every organisation, and that it doesn't just end up in one place or the other. But huge thank you to everybody, and I know our colleagues in the wider Hampshire and Isle of Wight fully understand and really want to lean in and support Portsmouth. So yeah, thank you.
Nick.
Yeah, it was just to add to the work obviously that's being done. I've been involved, as Carsten has as well, in going up to the AED to try and look at some of their processes and helping them map what's happening and looking at alternatives, looking at different ways for this to work, whether that's better access telephony to GPs for patients to go straight in, better flow through the department, potential diversion of patients as well. So there's obviously a lot of work that's going on. We've talked about this separately, and I won't go into a lot of detail on it now, but there's a lot of other stuff that's been going on to try and help the department out to make sure that patients that are getting there are patients that only need ED. and then making sure that they get to the right place the first time. It's a complicated issue, and I think it's not. If it's easy to fix, then people would have fixed it years ago. But I know that there's a sort of renewed vigour to some of that I've obviously been involved in. Won't be involved with it for much longer because I'm leaving, but I know that that's something which is ongoing. So it's just to add to that, really, to what Joe's already said.
Thank you very much, Nick. So any other comments or questions to Joe about that or anything else in the report? Jackie?
I mean, firstly, it was to recognise the huge amount of work that's been done. It's really come through the reports, and thank you, Joe and Maggie, for explaining, because there's some of the terms and explanations that I didn't understand. I'm not quite sure what the medical village is, so that would be helpful for a little bit more explanation. And then another report, I think, that's linked to this. We're talking about the UCR, Age Well UCR, and it's just trying to get a picture of exactly what it is, and sometimes I get muddled with the terms. And the question around SCAS is, I think in the papers or in the public, it's that the military may become involved to help support us, and I wondered what the position was there as well.
Yeah, thank you, Jackie. Hopefully you'll be able to pick up all of those issues. So in terms of the medical village, I think that's a term that PHU are using to encompass their sort of ambulatory care, same-day emergency care and short stay units. So what we would have previously perhaps called AMU. And that is really to make sure that they have the close working between those medical consultants and teams with the emergency department front door, so that they can pull those people who need to be admitted out of the emergency department as quickly as possible, because at the moment the bed occupancy numbers means there are often people in the emergency department who are waiting for an admission further into the hospital. So it's about creating that right flow and right process. And I think the concept medical village, again probably being used elsewhere and now coming to the hospital, Portsmouth Hospitals Trust, makes everyone feel that they're all part of the same thing, and it's not different specialties, they're all on the same team. So that's what that means, and it will enable, as I say, that pull off the emergency department into the right space for a short stay admission, or a same day emergency care treatment option. The UCR is urgent community response, and again that's sort of nationally what they're talking around, the term for how community services can support and work with primary care and local authorities to avoid admission. So that urgent community response is within 2 hours to avoid admission. So if a GP calls community service, if A&E or ED calls the emergency department, or if they get a call from the ambulance service, they're able to respond within 2 hours. Now, for us in Portsmouth, that's our PRRT service, the Portsmouth Rehab and Rehabilitation Service. It's an integrated team, and they have always had that 2 hour response time. So again, we're looking at how can we strengthen that and accelerate that and work that very closely with the PPCA services in terms of the clinical assessment service and acute visiting service to make sure we're able to keep as many people at home as possible. Does that answer those questions?
Yeah. I was just about the military and whether...
Oh, the military, sorry, Jackie, yeah. I think that's a really tricky one for us actually in Portsmouth, because we have the defence unit in Portsmouth Hospitals Trust. So in deploying the military, and it's often the military clinical teams that they deploy, actually that could destabilise us. So we have to be really careful to make sure that we're not pulling the military teams that we've got in Portsmouth hospitals elsewhere, because that inadvertently wouldn't help. So I think SCAS are looking at that more broadly, but we're really conscious that we need to make sure that defence unit at PHU is absolutely staying where it is and not influencing on that. And the work that the LRF have been doing in Hampshire and the Isle of Wight is looking at how police and fire can support SCAS as well with some of that as well, some of the emergency responders perhaps to falls or to the call centre. But I know Maggie's got her hand up and I'm sure can add to that as well.
Thank you, Jo.
Yes, sorry, I can see that Graham's got his hand up, but Maggie, did you want to respond?
Just very briefly to augment that, in some respects, the best thing that can happen is military staff from Portsmouth don't get deployed somewhere else in the country. So that would make a big difference rather than new people, but let's see. And as Jo said, our police and fire colleagues very much in the space of seeing how they can help in a way in the ways they did during some of the earlier peaks, and so looking to help, and they are keen to do more, and that's some of the very live work we're doing in light of the sustained pressures. So there is some more to come, which is good, and a bit more help. The other thing I just wanted to mention is when you remember during some of the worst times, we had police and fire who came into our acute hospitals and helped with proning of patients in intensive care, and that was really fabulous that they did that, and it made a huge difference to the physical workload and to be able to have that care, which is quite a physical amount of care. But what's really keen is they also brought their energy and their emergency response and their spirit with them, and that was really important and helpful for our ITU colleagues who by that time were under sustained pressure and really feeling the pressure, and so I personally do think our fire and police colleagues can also just bring some energy to NHS colleagues who have been, as Helen said, under this sustained pressure now for such a long time. So we are grateful for all our colleagues coming into this space just to really keep the focus on our NHS colleagues doing the best they can and making sure that we're able to give them the time they need off and look after them as well. So yeah, thank you.
Thank you.
Thank you. Graham.
Thanks, Elizabeth. Two questions. I think, Jo, you mentioned the urgent or emergency care centre that opened on the 1st of November earlier. It was just double checking. Is that the service that Nick was describing earlier, effectively, that he's supporting in doing that? And the second question was more related to social care. Obviously, we've had the legislation this month that meant if any care workers weren't double jabbed, they couldn't continue working. I just wondered if that's had any noticeable impact on care in the city. Yeah,
thank you, Graham. So in answer to your first question, yeah, the two are linked. So we have developed an emergency care centre which gives hair in my mouth, which gives additional spaces, about 20 extra spaces, chair spaces, to the emergency department, so increases their capacity, and again sort of ensures that those people who are fit enough and able to sit in a chair rather than be cared for on a trolley are able to be placed in that place. So again, freeing up some of the major spaces and moving people through the department more quickly. That's augmented with a high intensity team of primary and community staff as well to support the ED staff to do that redirection and signposting back into primary care via the CAS, the PPCA clinical assessment services, if that explains that one. In terms of social care, yes, you're right around the legislation. I think Andy's not on the call today, but my understanding is that actually we've been fairly lucky in Portsmouth with this, and we've seen quite minimal numbers of people who haven't been vaccinated, and I think that may be again demonstrable of the success of the vaccination programme, but I can see that David's got his hand up and probably wants to respond to that as well.
Well, it's right, Graham. It's marginal in terms of the impact on staffing numbers. That is a much broader factor than that. We are seeing loss of staff really due to wage levels elsewhere. and to an underlying shortage. But the actual vaccination element is at the margins. We are, unfortunately, we're beginning to get care packages handed back. Providers can't fulfil the service.
Thank you. Michelle.
Yeah, and just to add to the conversation and also to link in with the mention of finance, I think we should also be aware that the plans do rely on additional workforce, and clearly one of our risk factors that we're grappling at the moment is lack of workforce, and therefore we do need to be mindful of that as we work through standing up those plans. You know, have we been successful in actually attracting workforce, which is one of the reasons why we've decided to go at risk without understanding whether there will be a funding stream to cover off those additional staff. And also just to highlight that when I come to talk about my finance section and planning for the second half of the some of those plans are not currently contained within those plans as we speak, whilst we work through the more detail around them, and also, you know, seeking that additional financial support. So that clearly does increase the risk of the system not achieving its financial targets if we don't attract and are successful in standing up all of those services. So to that end, we'll be obviously monitoring that really, really closely as well, and working as a system, as we have done throughout, you know, the last at least 2 years, if not longer, to make sure that we're all aware of the financial pressures that we're facing and dealing with them as best we can. Hopefully that's helpful information.
Thank you all very much. Have people got any other questions about anything else on the report? And I'm sure we will be coming back to our urgent and emergency care position. Jo?
Yeah, just wanted to add just finally and picking up what Michelle said as well. And I'm sure we'll come back to this in the quality section, but I think it's important to raise it here while we're talking about it, that we must always be aware of the potential harm that the ambulance handovers delays can cause. And we've seen a national report out only this week, not related to our area, but on delays at the beginning of last winter, January were last winter, and the impact that can have those long delays on people. So I think it's important that we recognise and remember as a board that, you know, the quality impact and impact this can have on people as well while they wait. So that's again why it's so important that we're taking all the actions that we are taking to resolve the position. Thank you.
Thank you very much, Jo. And this remains a high issue on our risk register.
Yes, it does. It absolutely does.
Yeah. So we're being asked to note this report. Are people happy to do that? With the understanding we will come on to it in more detail from a different angle later. So moving on, we've got our Hampshire and Isle of Wight integrated care system development and transition. An update from Maggie, please.
Thank you very much. I think it's important to put this piece of work in the context of what we've just been talking about. What's detailed in the paper is the programme. You can see there how things are going, the things we're doing, and the progress we're making, which is on track. What will be really important for all of us is obviously the progress is. The legislation changes are going through their process, and we'll keep close on that. We need to do some work. We need to do safe transfer, and it's got to be proportionate, and we need some of our people working on that, and we've got some joint work between Portsmouth CCG and the Hampshire Southampton Isle of Wight CCG, and we need to really keep focused on that, avoid duplication, progress things, but recognise in light of the very real pressures. We can't deploy huge amounts of people onto this, and we've got to do enough to be in a safe position from April, recognising that this integration agenda we've been on this journey for a long time, and we will continue on it. So it's just trying to receive this report, obviously pick up any questions from colleagues, but to recognise that a number of us are working on it, but that we've got to keep the majority of people focused on the plans and not have people too tied up with this. And it's just getting that balance over these next 4 months. So I think I won't say any more because it's a repeat of some of the stuff we've been doing, but colleagues may want to come back and may want to test, and indeed David might want to add something, and likewise Joe, because from the different perspectives, very involved in this work.
We've got hands up from Nick, and then Margaret, and then Graham.
Thanks, Elizabeth. Yeah, thanks for that, Maggie. I think it's really obviously we've talked about this a lot, haven't we, at various different governing board development sessions. I was just wanted to ask, really, as I keep saying, I'm going, so it's maybe not something I've got such a vested interest in now. But where are we at with the time frame of the design of this and the sort of constitution? Because obviously time is marching on, and we'll be into the new year soon. Because the question I've been asking a lot when we've had discussions about it is how can we make sure that we keep the good bits? The thing that I've learned in my time, which is coming to an end, which is, how can we, we've got some really good engagement with primary care. I think it's been really good having the GPs that we have on the CCG. I think it allows us to be responsive, and people reasonably respect us in terms of asking for things to be done in a slightly different way. And I think that certainly when I've contrasted that with other areas, when I've talked to some of my counterparts in other bits of Hampshire, some of the GP engagement is maybe less good, which means that when you're wanting things doing differently, that you tend to get a little bit more of a no as the default option. And how can we, protect those sort of good bits? Because that, I think, is a real strength of what we have in Portsmouth, and the relationship with the local authority again allows that to be very responsive and collaborative. And that's the worry for me. And I've been asking this question a little bit before: is to how can we make sure that what we then have locally, what our place-based organisation, whatever that's going to be, how does that sort of protect that? So sorry, waffling on, but those are the couple of
and I mean, it's a really important thing, and we can't say it enough. And the constitution and the process for the people who'll sit on the integrated care board and the integrated partnership is going along, and there's pieces of work on that. But that isn't what really matters. Is the work in Portsmouth, in Portsmouth and South East. Now, the positive thing, all of that is not going to be controlled by the legislation, so we can get that right together. And we work that through. Linda probably will want to say something about GP engagement and what that might be looking like in the future with primary care networks, and again working closely with her opposite number, Nicola Decker. So I think all these points are there. I think we're all absolutely committed to keeping all the best. Pleased that we're not going to have to be legislated for everything, and getting this balance of what do we do in the city and when we need an absolute city focus, and when do we need that Portsmouth South East geography, which we're very mindful of at the moment because of the urgent care pressures, and then when do we need to do other things. So we are iterating it, lots of discussions, lots of work, and we're getting closer to nailing it, or at least moving a step forward and getting clear with the safe transition of staff behind the scenes. But let me bring others in, because people are here with colleagues kind of, if you like, wrestling this to the ground and getting a bit more clarity, and increasingly we'll do so over the next few months.
Can I just come back quickly, Maggie? Do we have a more sort of firm sort of timeline as to where we will be there? That was the part of my first point, really, was that I know lots of work's happening, and I don't doubt that for a second. I know people are working incredibly hard on this, but do we have a point where we can say, okay, at this point we think we're going to be there? That was sort of part of my first point.
Yeah. So on some of the questions, who's going to be on the board and all that sort of stuff, that we have to do all that, and that will all be going in. On the what will things look like locally and then system, I would say we're getting there, but we're not quite quite there yet, and you know, we need to do that. And my view would be we need to. It won't be perfect because we're going to be evolving it through winter. So we need to get to a position where we say, well, this is what it looks like, and then just get on and trial it and evolve it. But let me bring in other people who are you know, wrestling with it rather than me tell you from my perspective.
So can we go to Linda for the primary care bit?
Yeah, so yes, as you say, Maggie, working with Nicola, and we're trying to come up with a proposal that sounds sensible and doesn't have 100 people sat around a table trying to make a decision, which clearly can't work. So the idea very much having local groups of GP support, but with all primary care. So we're talking about nurses, physios, practice managers. How do you get their voice and represent it further up the chain? So that's something Nicola and I have been working on, and we're hoping to bring a proposal back to the local PCN groups in the next week or so, actually, so that we can try and thrash that out a bit more. We're talking about having a primary care collaborative that would sit underneath the board, but where a lot of the discussion and the nitty gritty would have to be worked out. And there's an understanding that the person at the board is there with the primary care head on, but as isn't a decision maker for all of primary care, because obviously primary care being an independent organisation. So it's more about that primary care voice rather than necessarily being this person that's going to agree everything for primary care, which isn't their role. So it's just being very clear about what that person is there to do. And then the most important bit is, how do we make sure there's lots of voices feeding up into those discussions? So that's something we're working on with Nicola. I'll bring it back once we've got it kind of a bit more nailed out.
Thank you. And then David, did you want to come in?
Well, just to say that the picking up Nick's point about the interface with the local authorities, the local authorities chief exec met with Lena, Paul Gray and Roz, I think that was last week, and we agreed that the task and finish group that was being set up to look at how the ICP, the partnership, was being formed, needed also to look at the ethos and so forth of the board as well, because the two need to be able to work together. And I certainly think that it will be to the board that the region will apply the pressure, and I think that therefore is where we need to be if we're going to influence some of these bigger issues and influence upwards as well as manage downwards. So I think that debate is ongoing, and hopefully that will be successful. I think that the issue around the place versus the sort of the acute footprint is something that we do need to keep an eye on. Understandably, the acute footprint has been the focus of all attention more recently, but a lot of the problems that are leading to that are around workforce. And those problems aren't going to go away quickly. So, if our management of problems like that leads to us sort of circumnavigating place and doing everything on the basis of acute footprint, that is something that we need to be wary about and make sure that our voice is heard. Thank you.
Thank you. Joe, did you want to come back in, and then we'll take questions from Margaret and Graham?
Yeah, just to add that I think so I'm involved in the design sort of task and finish group that David's referred to, and also the overall systems design group that's met a couple of times. And again, look, I think this engagement will really ramp up now about what does it need to look like, how do we want things to work, what are the principles that we're working on between now and sort of January, so that we're in a good place for that transition. And I think it's like we've said, it's important that we are it's important that we recognise that these aren't and or choices. It's how do we do all of it and make sure that we are working with the right partners in the right spaces, because not everything needs to be done at ICS level. We should be coming together there where it makes sense to do so, where we can work at scale and where we can learn for each other. That place is absolutely important and needs to be recognised. Again, lots of what we do absolutely needs to happen at place, and then again Portsmouth and South East Hampshire where it makes sense to do so across that footprint. So I think you know, they're not arbitrary choices. We've got to work a way of doing all of it through this design process, and certainly that's the conversations that I think are starting to happen. In terms of time frame, Nick, and your original point, I think that has been updated probably since the paper came, so we can get that out to board members. That just gives a little bit of clarity around the dates. The first submission of the constitution is in November, but that is very high level around who sits on the integrated care board, which is fairly well set nationally, to be honest, but everything else is later, so we'll get that time frame out to you as soon as possible. Thank you.
Thank you very much. So Margaret, then Graham.
I've got a couple of questions. One is, just reiterating some of that clarity about place, and really a question back to Maggie, really, about the Constitution will presumably give clarity about what decisions are made where, and what authority at each level there will be, and that place will be recognised as presumably the 4 unitary authorities. Question, because I'm aware there are district authorities involved as well, and that it will retain an importance. It won't be merged into the acute geography of southeast and Portsmouth, for example, or west and Southampton. So you kind of just really needing some clarity about the commitment to those things as we go forward, and recognising that it's complex and recognising that there are decisions that need to be made at scale. The other question I have is about health and wellbeing boards and where they fit in with in the Constitution. How is it proposed that they're involved and their role is included in any of the work around decision making?
So, Margaret, thank you for those questions. And we are not quite there, but we need to get to a position where we can write this down and people can say, well, I can see that. And we're not quite there because we are wrestling, aren't we, with all these different things. So again, you know, for the record, we're absolutely committed, all of us, that there are things that we do that are so focused around our local authority geographies. So Portsmouth, Southampton, Isle of Wight and Hampshire, and then within Hampshire, districts and boroughs. And we know that, and we've got to make sure that enough of our thinking and resource and decision making takes place in those places. And then we know for other decisions that those acute footprints, as we like to call it, are important. And we know for some the wider. And it's just, we've just got to get to that point of how it all works and how does the money flow. You know, we won't do it all overnight. We will evolve it. And, you know, we've got to do that together. If it, as Nick said it earlier, if it was really easy, we'd have just done it. This has been Hampshire and Isle of Wight's kind of thorny issue. But I think we've got trusted relationships. We all know what works, and you know, Joe's just said we have to do. You can't do one or the other. You have to be able to respond. But we've got, if we are going to improve the health and well-being and the experience of all our patients and the people who live in our communities, we can't view everything through the lens of an acute hospital. We need to shift. We need to shift our resource. We need to shift our thinking through an inequality lens into a well-being, wider determinants lens. And to do that, we need to do it in the geographies that are more akin to local authorities. And that's the complexity. I think in parts of the country where the two things are all coterminous, it's so easy. They just get on with it. I think the strength for us is because we're having to think about it and keep talking about it and keep wrestling down what it means to us, what's important. I think that's our strength, actually. In the end, we'll be in a strong position because we thought it through deeply, as opposed to perhaps places where it's just coterminous and people sort of carry on. So, we'll only do this together, Margaret. We'll work it through, and we'll keep coming back. And as Joe said, we'll bring that revised timeline. I'm sorry that wasn't in the papers and should have been, and then you can see that. And we just need to keep challenging and supporting each other and getting on with the job. So I hope that's helpful. But I do recognise until it's landed, until people see it there, rightly so, you and others are going to keep asking us, and you must do that. Yeah.
The other part of that question was around health and wellbeing boards, I suppose, and they exist. They're statutory. We clearly need a link. So I just wondered how that. I mean, I'm not asking for questions where you're still working on it, but it just needs not to be forgotten.
Yeah, I mean, not forgotten. And I'm just looking to David actually, because David, you were at that meeting last week when I wasn't. You were with your local authority colleagues and Lena Samuels, and all of this stuff was on the agenda. Is there anything from that you can give some comfort to Margaret that, I mean, we definitely haven't forgotten it. Was there anything you wanted to share?
Well, I think this is where the sort of the ethos as well as the constitution of both the partnership and the board are really important, because there's actually quite a bit of flexibility in terms of who, the numbers on the board. So there is scope there to flex. But the extent to which, for example, the local authorities would want to be represented by their place compared to by the functions of a local authority will be hugely influenced by the trust that they have in the ethos of what's being created. You could have, and it was advocated by the county council at that meeting, that you could, all four of the upper tier local authorities could be represented on that board. Or we could have representation from a chief exec, a DPH, a DCS and a DAS. They're different ways of cutting the representation and the voice of local government. It would be great if we could convey to local government sufficient confidence in the primacy of place that they felt comfortable to move forward more thematically. But that's why you need to design the roles together. You can't do one and then move to the next, because you'll miss the trick then. In terms of the health and wellbeing boards, clearly that interface is really important. You'd expect it to see reference in the constitution of the board and the partnership, because it is the only other statutory body really kicking around on a multi-agency basis like that. We're certainly doing work to try to strengthen the role and the ambit of the Portsmouth Health and Wellbeing Board in full recognition of that.
Thank you, Graham. David, thank you. Graham, you've been waiting very patiently.
That's okay. Mine was just a quick one and a suggestion. In light of the constitution, and I appreciate what Joe said, that it would only be perhaps the higher tier of that ready at the end of November in the timeline, whether there's an opportunity for us at the development board in December to have a first look at that.
Yep, I'm sure we can. So there is a draft, but as I say, the initial submission is really just about the people on the board, and a lot of the detail, the scheme of delegation, and operating model, if you like, is contained within the governance handbook. So again, I think that gives us some flexibility that this can be developed, can change post-April without having to re-engineer the whole constitution. But yeah, I'm sure that should be possible. We can speak to Paul Gray about that. But I think it's just it's really just the core members of the board at this stage, which we did discuss last time, but we can absolutely bring it back again and look at what needs to go in that governance handbook around scheme of delegation, etc.
And Joe, you had your hand up anyway, so
it was to say that, because I didn't want the board I wanted to make sure Margaret hadn't misunderstood what I meant when I said that there was a submission of the Constitution in November. It's not the detailed Constitution that we would recognise with CCGs. It is just about the makeup of the board, and the scheme of delegation, etc., sits underneath that in the governance handbook. Just wanted to be really clear for everyone on that. So again, it gives us the time over the next few months to work together to design the ICS.
Thank you very much. And I have to say, I am still a little unclear, and I'm sure I'm not the only one, about the differing roles of the integrated care partnership and the board, and those relationships seem to be key. Coming from the city, where our joint working, our very collaborative style is predominant, my view would be that partnership is the key place, and that the board supports the partnership working. But at the moment, I get the feeling that the board is more likely to be in control. I just think it really needs some sensitive handling, but it's really important because people are not just health, and health does not work alone. We've already talked about needing help from the military, from police, from fire and rescue. You know, we are more than health, and we should be focusing, in my eyes, on that partnership model. That was everything that integrated care systems originally started out talking about, and there feels to me to be a risk of hunkering back down into health and battening down the hatches. I think it would be a real shame. We could be a trailblazer by getting that balance right and getting that true partnership working, going to the benefit of our whole population. I will come off my soapbox, and we've then got David and Joe on the next paper, working towards greater alignment in the city for Health and Care Portsmouth.
Okay, I'll kick off if I may. So this is item 6B. I guess this is what Nick would describe as a continuation of the good bits, I hope. This is a continuation of our integration journey, based around place in the jargon. It's aligned, I believe, really strongly with what was said in the white paper and the subsequent guidance. It builds on the principles set out in the Health and Care Portsmouth blueprint and the processes set out in the Health and Care Portsmouth prospectus. So it's squarely in line with that. It's designed to further develop our work as co-joined work around the co-production and design of services, joint commissioning, the pooling of resources, greater transparency about how we spend our money and how the Portsmouth pound is spent, and through that better effectiveness and efficiency, and most importantly, of course, better outcomes for our population. I think, in the light of the previous conversation, I think what I'd say is the better our house is in order, the better able are we going to be to support the work at the Hampshire and Isle of Wight geography, and also at the Portsmouth and South East Hampshire geography. So I think it's really important that we continue with this. Section 4 sets out what we're doing under the auspices of the Joint Commissioning Board, and particularly looking to refresh the Section 75 agreement, the arrangements that we've got under through that. We've taken advice on this in terms of creating a single overarching agreement with schedules that can deal with things like the Better Care Fund, continuing healthcare, children's various aspects of children's social care, and so forth. And section 4.7 there sets out the scope, really what's in scope there. I'm keen that we expand the range of elements of the local authority spend within this. At the moment, we've got a number of areas included. I think not just to increase the joint influence that we have, but also symbolically, I think it's important that we can use this to demonstrate the significance of our work across the wider determinants of health. So I do think that there's scope, further scope there around areas, aspects of community safety, for example, aspects of housing support. So we're working jointly at that, all of which designed to give us better leverage in terms of our design for more seamless services. So that's all underway. I think at the moment there's about 100 million in that pool. We think that could double. I think that would be really good achievement if we managed to do that. The final bit of the report is specifically around the Better Care Fund and the submission that we were obliged to make yesterday. So we're a little bit back to front on this, but only by a day. So that submission has taken place. Again, it's absolutely in line with the Portsmouth Blueprint, that it's focused around our work, our integrated work around out-of-hospital provision, around the avoidance of admission to acute, and early discharge and discharge to D2A as well. That will be going on to the Health and Wellbeing Board on the 24th of November next week. But we are seeking specifically for the board to note the specific resource allocation in section 6 there today, Chair. So there are three recommendations: to support the work underway, to confirm the role of the Joint Commissioning Board, which we reported on at the last meeting, and to note that specific resource allocation in relation to the Better Care Fund. Thank you.
Thank you very much, David. Joe, did you want to add anything to that?
No, not really. I think David's covered everything, and only that we had secured Councillor Fazackley's agreement to the submission pre-sending it off, so we did manage to get some of it signed off in his role as chair of the Health and Wellbeing Board. And that I guess for us, we already met the minimum conditions from the CCG perspective, which were uplifted this year, but the BCF and that partnership working around it is very much a business as usual approach for us, really.
Lovely, thank you. So we've got questions, Jackie, then Margaret.
Thank you. I completely support this position. I really do, and I bless you. Sorry. My only comment, I suppose, was to Maggie, really, as we're all of us building the ICB and the ICS, and this, does this feel like a structure that would sit well within the system as you see it? It looks good from where we are from Portsmouth, being well integrated and being able to deliver as one city. Does it sit with the bigger picture as us with our ICS hats would like it?
Yeah, I mean, I think it does, because we've got this strong joint commissioning actually everywhere. Everywhere's at different stages, and that's not it's just how life is. And I think that working together, learning together, having conversations between us about what does good integration look like, and what are the features of it, and where is each local authority with its system at the moment, and how do we take steps further forward. So I think it's good. As I say, everywhere's a bit different, but I think this it's a good model, and we need this needs to be everywhere, because it's an important part of what we do together.
Oh, thank you, Maggie. That's really encouraging, just so that as a system and as a locality and as across the acute, we're kind of all singing from the same song sheet, I suppose. I find that really encouraging. And I was just, my other very quickly is, who sits on the partnership management group that oversees the Better Care Fund? Do you know, Jo?
Yeah, so at the moment, well, we've now changed that slightly so that the PMG will report into the Joint Commissioning Board, as will the Continuing Healthcare PMG as well, and that may change the membership, but at the moment, myself, Michelle are on that board, Andy Biddle from the local authority, and representative from PCC finance team as well, and then there's a collection of others, but we're the sort of the main people on the board to create that shared decision making. We have looked and gone round several times with the PMG around whether or not we invite provider colleagues onto that. We haven't done that for the Better Care Fund PMG, but on the Joint Commissioning Board now we do have provider representatives from Solent, from the Acute Trust, from the Hive, and from Portsmouth Primary Care Alliance. Again, at the moment they aren't in the decision-making sphere, but they can absolutely be part of the conversation and influence that, and we see that as being really important as we move forward into the ICS space.
Yeah, oh, thank you. That's really helpful. And then, of course, we've all got double hats on because we've got an ICS hat on as well as a locality hat on, so it should knit together really nicely. Thank you.
Margaret?
I suppose my question is a forlorn hope that at some point we might move from the focus on the acute
Yes, I agree.
And move to that wider population. Now, at the moment, I understand absolutely why we're focusing on acute, and
I think Margaret's reception is somewhat intermittent.
check me out. Oh, hold on. All the ambition around wider determinants of care and prevention and self-help, as long as we continue with that top end of the pyramid, focusing on acute. And I have to say, I've been involved in the assurance process for the Better Care Fund for the last 4 years or so. This year, I just couldn't bring myself to do it because that's, again, another focus which reinforces that the importance of, and absolutely I understand it, the importance of urgent care, but we do need to start looking at that wider population that we all serve. Sorry. I'm off my platform now.
Thank you very much, Margaret. Maggie, did you want to come in?
Yeah, I mean, just again to reinforce this, because you know, we all know why we're focusing on this at the moment, because we have to, and that's exactly, none the least, because of the actual and potential harm. But we have got, you know, if we carry on doing what we've done, we'll always get what we always got. So there are, as a group of healthcare and public sector across our patch, you know, NHS money we're going to have in the order of 3.4 billion, and we all tend to think about how much more would we like, but that's an awful lot of money, and we need to have some really high level conversations that aren't lost in the detail about, you know, of that money, what should we be spending where, and how do we make some relatively small shifts into prevention, primary community mental health? Because actually, when we look at that big pie of what we spend, because they are the more expensive end of services, we're spending a huge percentage on those kind of services. And over a period of time, we have got to shift it, keep our acute sector vibrant, of course, physical and mental health, but we've got to get that shift, and we'll only do that together. So I'm really encouraged. I know David and Linda were there as well, because I think we've seen, as a group of leaders across the geography, more people really getting that and understanding, and then we'll need to make some decisions and make some choices, so that over a period of time, we see some investment shift, but we also see that focus shift, you know, so that ultimately what you can only describe as symptoms, which is what we see with these acute pressures, that by putting more emphasis right further down the track. That's how we get out of it. And, you know, our job as leaders, isn't it, is to handle that we sort today's problem, because that's what we absolutely need to do, but that we have got a real focus on some steps, real steps. And those steps obviously need to be greater than they have been, else we wouldn't still be having the problems in Portsmouth. So that's the thing, isn't it? We've done well, but we've obviously not done well enough, or things have changed and we haven't been able to respond quickly enough. So yeah, we've got to keep ourselves very focused on that.
Thank you, Joe.
Yeah, no, completely agree with that, Maggie. And Margaret, you know, welcome your challenge to push us into that upstream, that prevention agenda, and into the wider determinants. And I wonder if it would be helpful for us on our development session. And I've also put a similar comment, just as we were talking into, or thought into, the PCC directors as well, when we meet, because actually I think the way we want to structure the overarching Section 75 with schedules, rather than putting everything together into the BCF, because that was an option, but actually we felt it's a schedule within a much broader coming together, perhaps in our development session in December, and with PCC directors as well in their meetings, we could think about what else could we do, and how would we share, how can we demonstrate that shift, and how does the schedules that we're thinking through in this work, how will it help with that? So perhaps that's some actions we can take at a more local, practical level, alongside the strategic work that Maggie's talking about that needs to happen as well.
That sounds very good. I just wonder whether we shouldn't be meeting as a board with the PCC directors.
Yeah, that might. Yeah, that's quite.
Why not do it once together?
Yeah.
It's a possibility. Let's think about that.
But yes, certainly look at setting that up and seeing if we can accommodate diaries or something. But yeah, that would make sense. When, as I was talking about it, I thought, I need to make sure it's separate, because they're separate conversations. But actually bringing it together would make much more sense.
But it is on those two levels, isn't it? It's the practical day-to-day and that high strategic thinking bit as well. David?
I'd certainly support that. I mean, normally you have 3 or 4 of us on this board anyway, but it would be good to get others on there as well. And they are represented in the Health and Care Portsmouth executive meetings as well. And, you know, some of them very, very significant in that, particularly, for example, housing.
That'll be good. Right. So we're being asked to support the work underway. People supportive of that, and confirm the Joint Commissioning Board is the appropriate body for oversight, and note the specific resource allocation. Everyone's happy with those? Thank you very much. I am aware we are behind time, which is unusual for us on this board meeting. Personally, I feel the conversations we are having today are really important for our population moving forwards. So I'm going to overrun. So I apologise in advance, but I don't apologise. I think this is work we need to do. And so we will continue having the robust discussions we're having. So moving on to 6C, and this is Joe's bit.
Yeah, and again, might help you in the overrunning, Elizabeth, because I guess really what we wanted to pull out of here was, although there is a much broader transformation programme around Portsmouth and South East Hampshire, where we come together under 3 programmes, the Managing Flow, the Place-Based Care, and the Healthy Communities. So where we come together across all aspects of work where it makes sense to do so, and how our locality work in both Portsmouth and South East Hampshire feeds that. It was really to note that actually, because of the focus we're putting on the ambulance handover delays, which we've talked about already and which we might pick up in other items, some of that work has been paused, and the reporting of some of that has been paused, because we're refocusing how we report and how we programme manage the work under that ambulance handover delay. So that was all I really wanted to say under this item specifically, unless anyone's got anything they want to add at all.
So, Graham?
Yeah, it's just a comment more than anything, Joe, that in terms of the board visibility, it was really good to see the healthy communities, because I think that's the most detail we've probably seen at board level of that, and that's really started to talk to, you know, the agenda we've got around health inequalities and what we were talking about earlier, wanting to give more focus in that area. So it was just to say it was really helpful to see the amount in the board on that, and that's something I'd kind of like to see going forward as well.
Yeah, thank you, Graham. And when I say we've paused some of the work, it's recognising that so much of this does feed in and will support the ambulance handover reduction in the longer term and sustainable solution. So it's really about just making sure that we're not asking people to report things twice or have a cumbersome reporting structure. We're also doing some work with NHS England potentially around that population health management with a piece of work called from an organisation called Lightfoot, which again may help us identify some of those high intensity users more easily, more quickly in the short term, but then will be able to be built into our more sustainable population health management approach. So lots of work continuing around that healthy communities, but we're just making sure we're not overburdening people with reporting on it at the moment.
Jackie.
I had a couple of what I hope might be quick queries, but on the mental health front, because that's also something that sometimes might get lost sometimes in our conversations. The first one was around the accommodation challenges for the mental health liaison team at QA. I don't know where we are with that. And was there any lessons to be learned? Because it's noticeable that at Hampshire, people entering treatment for IAT is far more than at Portsmouth, which surprised me. So I wondered if there was some learning there. That's where perhaps we could do a bit of cross-area learning. And my last question, I suppose, was around provider resilience. And I just wanted to clarify I'd got this right, where it says the redirection into all primary care entry points and to enable slots to be booked without clinical triage.
I think that might
in my head. That sounds like a typo, maybe.
Yeah, I think that is a typo. I can pick up on that. Was there any more points you wanted, Jackie?
No, that was it. There's the two on the mental health, and just to clarify that one, because that didn't sound correct.
No. So the first one, in terms of the mental health program, there's been a perfect week that was done recently, and again looking at where do people enter the emergency department, or how do people enter the emergency department for mental health conditions, and could they be better managed elsewhere? And that's brought some really interesting points and some themes out that the Mental Health Leaders Group are looking at. That work is continuing, but recognising that they are very low numbers, although have a very high impact in the trust. That work continues alongside, but is not perhaps as visible in the work we're doing around the ambulance handover at the moment. But the work, absolutely want to assure you that the work is continuing as we continue to learn from that. In relation to IAPT, yes, absolutely. I think that is something we could look at. We've always had a bit of a challenge about numbers into IAPT, and I think that's because we have a different makeup of community services, so that referral goes elsewhere, not necessarily just into IAPT. So Positive Minds is another example of that, and the way we support long-term conditions as well is another area that we've looked at for that. So that was those two. And then in terms of the primary care, I think I think it is a typo, but from South East Hampshire perspective, they have been doing work with their practices to look at how they can better manage the 1 in 3,000 appointments that all primary care practices are required to submit through 111, NHS 111. We cover that off through the clinical assessment service in Portsmouth and the PPCA service. It's a slightly different model in South East Hampshire, although they do that as well. It's looking at how can they enable people to be managed back into primary care. And again, it's doing that so that you're not sending people around a endless triage loop. So it's not without any clinical triage, but it's making sure that you're not doing that in a duplicative way, if that explains. But it's more of a South East Hampshire piece as they develop their model. There are some subtle differences. Broadly, they're exactly the same, but just that route back into primary care differs slightly because of the geography and the makeup of their PCNs.
That makes a lot of sense. Because, yeah, it does help a lot. And it was exactly what my query was. Joe, you've answered that, is that we're just sending people to what we hope take about one pressured area, stick it in another, and then end up in another, then end up in another.
Yeah, and making sure we're not doing endless triage within that. But I can see Bernie wants to come in to add to some of that, maybe with the detail around IAP perhaps.
Yeah, sorry, it was just on IAP to apologise for an error on the target for the dashboard. So the target for the population access is based upon head count. So the reason Hampshire and Isle of Wight's numbers are so high is related to the area that it's covering. So the population number is significantly higher, and currently on target to hit or improve its referral rates. It's actually about head count in the population rather than percentage of the population. And in terms of percentage of the population, we are both broadly comparable. But the dashboard, Jackie, I'm sorry, has got an error in it in terms of the comparative number, and the number that's currently showing for Hampshire is the Portsmouth number. I do apologise.
That's okay, Bernie. Thank you for explaining. Appreciate it.
Thank you very much. So we're being asked to note that. Happy with that? Thank you. They've been very useful, those reports. Can we now move on to the finance reports for Michelle, please?
Yes.
7A.
Yeah, certainly can, Elizabeth. Hopefully you might be able to catch up on some time.
Correct.
I wasn't planning on saying too much. We've obviously talked about some of the risk around the ambulance handover plan, so I wanted to highlight that to the board. So we've done that already. So in terms of this finance report, I'm pleased to say that the CCG did achieve the half-year surplus position as we've previously been reporting. And as we talked about at the last board, we're immediately into talking about the second half of the year, and that planning is still ongoing. Submission is actually now delayed until tomorrow, so we had a couple of days grace. In terms of Portsmouth CCG, we will be showing a small surplus in this iteration. Hampshire and Isle of Wight wide, we're not currently at a break-even position, which we know is where nationally they would like us to be, but we're recognising that we do have some risk around the elective activity in particular. If we still want to continue with that, that comes with slightly more expenditure than we're expecting income for at this current moment in time. There is still guidance coming out and understanding of how some of those funding streams will be released to us, so there's some risks in play there as well. And then we'll work through the outcome of that process once we hear some feedback from the national view, and indeed whether there are any other elements of funding that might be available. As I said earlier, currently our plan around the ambulance handovers is not in that submission, and that also brings some added pressure and some added risk, which we continue to talk through as a system. So some really good engagement across all organisations to get us to the position we're in to make the submission tomorrow, because the position has been changing on a daily basis and was far worse a week ago than it is at submission day tomorrow. The only other thing that I wanted to highlight to the board again is that once we finish this submission, we'll obviously be talking about 22-23. We heard yesterday at an update from the Chief Finance Officer of the NHS that we're expecting planning guidance to come out mid-December. They were obviously trailing some of the pressures that remain in the system around. There is extra funding, as and Maggie alluded to our number earlier. We're awaiting allocations, which hopefully will come out with that guidance, so that we understand some of the funding flows that we have been receiving on a non-recurring basis. Hopefully, will come into the system on a recurring basis, and then that will help us in our planning process going forward. But we already know that the expectations are that we need to be looking at efficiency and productivity, because the comparators from where we were pre-COVID are showing a deteriorating picture we're not even post-COVID, are we? At this moment in time, so we need to be making sure that we're addressing that issue. Hospital discharge funding, for example, is due to finish at the end of March, so we need to be planning for what that means going forward, and we need to do that with our partners as well, don't we, in local authorities. I think those were the main headlines, and clearly elective recovery is high on the agenda as well. So I just wanted to brief you that as soon as we stop doing one thing, we'll be going straight into planning for 22-23. From the briefing we had yesterday, I think we're going to get 1 year allocation in terms of revenue, but probably a 3-year allocation in terms of capital, and that will help us plan a little bit further ahead than we have been able to do over the last couple of years. So I found something positive. I'm happy to take any questions, but hopefully that's helpful for the board to know where we are at the moment.
Thank you. I think it's a great achievement to have made the surplus as planned. It's all credit to you and your team working across, so well done. Other questions, comments from anyone? Well done, Michelle. You've stunned everyone into silence. If we move on, we're being asked to accept the contents of this report, noting the achievement. People happy with that? Lovely. Thank you. So item 7B, Bernie with the performance report.
Thank you. Again, with time, but not wanting to skip over the issues. In terms of a summary of the report, newly reported at page 3 is the Q1 performance with regards to system oversight framework. As an ICS, we were placed into level 3, which is towards the higher end of the grading, indicating that we would be under tighter regional scrutiny. And Portsmouth as our main acute provider, along with Southern, are on level 3 as well, with Solent, our main community provider, being on level 2. And I think the issues around those performance we've all pretty much alluded to already. In terms then of performance specifically, at the moment, we have a number of patients and an improving performance around 52-week waits, and we had one patient at PHU waiting over 104 week, but we had 4 patients for a CCG, with 4 of those actually waiting for treatment outside of the immediate footprint, 2 at UHCS, 1 at UCL, and 1 in London, another hospital in London. I think it's important to note that as we go into submitting the H2 numbers that Michelle has already alluded to, PHU have submitted a plan that basically commits to no patients waiting longer than 104 weeks at the end of the financial year, and a 50% reduction in those patients waiting 52 weeks, although the waiting list will continue to increase up until through and past the 31st of March. And then really to draw attention to the factors that we have discussed, that we have noted an improvement in the number of people entering psychological therapy, but we still remain below target, and that we are not achieving our waiting times for children and young people accessing eating disorder support. In terms of the metrics updated for urgent and emergency care, probably draw attention to readers, for the reader's attention, to the current, the PHU performance on urgent and emergency care pathways up until the 4th of November, which is shown on page 15, and SCAS's formal reported position is on page 18, although subject or due to the timing of this report, we're just literally on the cusp of updating the next month's set of reporting, due to Superstats happening on Thursday of last week, but broadly the position remains the same. And take any questions?
Goodness me. Jackie, and then Maggie.
Actually, Bernie, was to say thank you. I think this report is great. I found it really easy to follow. Seriously, and it was really, really helpful. The question that I had was about the pathways into positive minds and the long-term condition hubs, and I was wondering what was happening or what the challenge to us was. I don't know.
There is me.
It was on page 19.
Are you talking specifically around
mental health ambitions on page 19, the actions we're taking?
For the long COVID or all of them?
I don't know. With Positive Mind, I presume that was a mental health programme, but the long-term conditioning hub may well be to do with, I think there was a hub for people wanting to get into employment, I think, who may have a mental health condition, but don't trust my memory for that.
I can follow up with Kerry afterwards. I don't have the detail to hand at the moment.
Okay, that's it. And then I think just the very quickie was on page 14 was regarding QA publishing a tender for ultrasound for an insourcing service. I just didn't know what that was.
That's for them to increase their sort of capacity for ultrasound. Insourcing is that another company provides it within their footprint, but it's to help with their capacity with their waiting times for ultrasound, which is currently under some pressure.
Yeah, I guessed it might be. I didn't understand that that was a private company that would be under their footprint that would do that work. And it will be interesting to see, or hopefully see, a reduction in that waiting list for diagnostics, because it's been a struggle, put it that way. Thank you.
Maggie.
Yeah, thank you. Just to come back to this sort of mutual aid and working together, the 104-week waits, which is an awful long time. It's predominantly orthopaedic cases, but in order to, they just happen to end up in one place, and it happens to be more in Southampton. So we are going to need, as a group of acute trusts, to work together to really get to those very long waiters and get through this crisis. So it's another example on a different agenda, when the only way through for everybody is to work together. So there is some very good, I have to say, mutual aid work to try and manage that through.
Thank you. We've got Carsten and then Simon.
Hi there. Hi, Bernie. Thank you for that. Just a query. On page 4, the alert advise assured, general practice is still sort of is assured. It says more patients assessing GP appointments with the expected target being met. I'm not sort of quite sure, with general practice possibly falling over, whether that is everything is so assured. I mean, shouldn't that also be sort of at least yellow, or possibly what's the combination of yellow and red? Sort of orange. It's sort of it sounds a bit sort of yes, target is met, and then we go to the antibiotics. I mean, I'm glad we're not adding to the resistance, but just wanted to sort of point that out, that may not sort of reflect reality, sort of.
Yeah, I think I would agree with you, Carsten. I think it's an interesting metric, isn't it? So it's fine that more people are accessing GP appointments. So that sounds really good.
Yeah.
But it's not real life for patients, nor is it real life for practices to say it's assured.
And also the newspapers state the opposite. And of course, there's the GPC voting on whether we should, whether sort of industrial action should be, or contemplating. So I'm not quite so sure whether everything is so green. The shoots are green. What are the greens? The shoots?
I think those metrics are green, but it doesn't mean primary care is in good spots.
I'll let it rest. It's fine. I'm happy with that, as long as.
Would that be a fair comment, Bernie? That the metrics, well, we can't dispute those because we know more people are accessing general practice. Yeah, I think it is. We are well aware that primary care is under massive pressure, and work is ongoing to look to see how best to support practices. But it's difficult times.
Yeah, because I think we're still in all of these. We're still very secondary care focused. I mean, everything is secondary care. And again, if general practice collapses or falls over, or is incapable of producing and pulling their part, we risk the whole system. We work together, but again, general practice is an very important aspect of the whole merry-go-round. Yeah, I don't. I've just wanted to sort of emphasize that. Yeah.
Thank you.
Very secondary care focused, yeah.
Indeed, and life isn't it? And as Maggie said earlier on, we need to look at how do we do that refocusing? How do we shift into primary and community care and get the focus and the resources and the workforce in the right place where people want to be looked after, and where it makes more sense for it to happen. Simon.
Thank you. Hi, Bunny. Just a quick question. On page 12, it talks about kind of supporting certain specialties that are under particular demand, kind of ENT, oral surgery, and ophthalmology within insourcing company. There was a mention earlier in the kind of governing board papers of kind of an ICS Eye Health Alliance meeting, because it seems that the ophthalmology is a particular issue across the whole patch. Is this insourcing company something that we're doing locally to recover, or is this more of a broad-pieced recovery using insourcing company?
Sorry, the mute one come up. This was more specifically to PHU for their response, but I'll follow up and find out what the ICS position is and whether it's a wider approach.
Okay, perfect. Thank you.
And then we've got Linda and Sally.
Sorry, thank you. Mine was really in response to Carsten's comments. we have acknowledged, and I think everyone acknowledges, it's really difficult to comment about capacity in primary care because we do just soak up demand. And we have been talking, certainly in our PSEC meetings and the meetings that Maggie talks about how we're trying to solve these problems, about how we share the risk. But the risk may be in primary care and community care, and it's not so obvious. You see it in secondary care because there's queues at A&E, or you see ambulances outside the front door. Primary care and community care is harder to judge, and so there is conversations about how do we monitor risk in primary and community care so that the whole system, when we're struggling, can wrap around us, just like we do with ED. That is live conversations, but obviously not such an easy fix.
Thank you, Linda. Sally.
Thank you, Chair. I just wanted to mention the issue of mental health support for children, in particular the Tier 4 beds problem, which is clearly an issue within the health system, but it is also an issue in children's social care. This was raised this morning in the Safeguarding Partnership because of concerns around children who are in desperate need of Tier 4 beds, and there just aren't any. And it's just an assurance, really, that through various other networks, these issues are being raised and flagged through colleagues in the police, through their networks, through Ofsted, through the DFE, etc., just to support the fact that we, all of us, recognise the critical nature of this. It's putting pressure throughout the whole system. And we urgently need the government to join up its thinking between departments to be able to find a system-wide resolution to this problem, because it's not just a health problem, it is a system-wide problem, and we all have a part to play in that. So it's just an assurance, really, that we're doing what we can through other routes to support any issues we can in respect of an increase in Tier 4 provision for these needy children. Thank you.
Lovely, thank you very much. That's really helpful. So, any other comments or questions of Bernie or anyone else? Otherwise, we're being asked to accept this performance report. People are happy with that? Lovely. So we're moving on to 8A, Quality and Safeguarding Report, and this is with Tina.
I think it's me, is it?
Oh, right.
Tina probably knows it better, but I have a...
Sorry, it was just that
I'm not the board representative for quality care.
I thought you were here, Tina, because
I'm here for the safeguarding. I'm here for the safeguarding.
Okay.
But I'm here if there's questions.
Fight it out. Karen,
I'll take us through the October Quality and Safeguarding Report, and then I'm sure Tina will add anything in she wants. So this is, as I've said before, a new report, and it's aligning us with the sort of the other CCG and the way in which they're presenting for the future ICS. The first slide is around the system summary, so not necessarily around Portsmouth, as I've said, but the broader risk issues. One of the ones that I wanted to pick up was around the Tier 4, which Sally's just spoken about. We talked particularly at CCG about the impact, not just Tier 4, but people waiting, that we've got children waiting on our paediatric wards who are quite challenging, got quite behavioural issues, and that's obviously having an impact on the paediatric unit. We talked about the fact that there's probably 3 cohorts of children within our paediatric unit: those that are coming in that are unwell, those that are waiting for our Tier 4 beds, but there's also a cohort of autistic children and children that need another placement, but have come in through PHU and are now causing some sort of disruption on the ward, and this obviously impacts on all of the ward. We talked about this. What we were saying is that this is, as I said, it's broader than just Portsmouth, and actually most of the children are Hampshire. But what is being done at the moment is we're looking at, or there is a team of people looking at the last 13, I think, recent children that have come in through Portsmouth, and look at their journey and then see if there's any learning from that. And what we've asked, CCG have asked for, is a deep dive report to come back, so that will come to the governing board. So we'll be able to see those 13 children that have come in to the paediatric ward and waited for an ongoing bed, what that pathway was. So whilst that is a system issue, there is some specific work around Portsmouth happening. If I move us to the slide 2, this starts with innovations and improvements, and we're starting to see that these are expanding each month, which is good news. The one that I wanted to pick out was that the PHU's IT department are going forward for HSJ award for their introduction of Bob, who is a digital worker. But also we learned today that SCAS are going forward for the Team of the Year award. I understand those awards are the award ceremony is tomorrow, so we should hear the outcome of both of those tomorrow, which is some positive news. The slides then go on to look at the risks specifically for Portsmouth. So we've got the red, amber, green, and as there's been lots of conversation today about the ambulance handovers delays, and obviously this is noted within the QSEC report, and there's quite high risk on our quality report. As I think Joe mentioned earlier, there was a report that came out from the Association of Ambulances Chief Exec report that came out earlier this week, and they did a clinical review of weights and the quality impact on people, and there clearly is a significant harm to people who have to wait, particularly those people that have to wait over 60 minutes before receiving treatment. So it is a quality issue with people having to wait in handovers, but I think we've heard a lot about what we're trying to do to address that current issue, and it's a national issue, but it is a quality issue. If we go down into the amber risks, we've got one around BPAS, and just to update you, this is the early medical abortions. We've had a response back from BPAS regarding their safeguarding of young people. We're still looking at that and looking have escalated that nationally. We'll wait the outcome of what they're saying, because we've got some concerns around what's being advised, and that's it's not in keeping with how we think certainly young children or young people should be treated regarding early abortions, but we're looking at it response nationally before we address it further. The other one is some good news around dental provision for looked after children. They're looking at offering additional appointments which will increase capacity, and there was something around issuing a script for foster carers and social workers so that they're aware of their statutory responsibilities, and that seems to have had an impact around dental care in the city. I think they were the two ambers that I wanted to pick out. We talked also today earlier about the compulsory vaccination of care home staff, and I can confirm that at the quality committee we also agreed that this hadn't had an direct impact on our care homes. And the PC primary care network vaccination incident, that was discussed at the SI panel last week, I believe, and it will now be communicated out. So they're the risks. Further down the report, there is 2 deep dives, but they're fairly self-explanatory. And then just the thing to say under safeguarding, there was, I think, the Pamela SAR was due to be published in October. The family have had quite a few comments about this report, so it hasn't yet been published. That's all I was going to say, unless Tina wanted to say any more, but have you got any questions?
Right, Sally. Sally, did you want to come in?
It helps if I switch off my mute button, doesn't it? The 13 children that you're talking about doing a deep dive on that are coming, presumably we will be assisting you with that. Are you going to ask us for some help or some input into them with those children?
You're actually leading on it. Anthony was.
It's with one of my team. Okay, that's fine. I hadn't caught
up. You're leading it. But we were interested to understand the outcome of all of that, and so you agreed to do a deep dive for us.
Okay, thank you.
Jackie?
Thank you. There might be a little typo, but I'll check with you, Karen. Is I to I supposed to be A to I, assessment to intervention?
Does sound like. Where are you finding that, Jackie?
That's on page 1. Oh, right. The system summary 1, the third one down.
I to I is the Old Testament version of A to I.
Oh, is there? Okay. You got it.
Yeah, I've got it. I don't know. I'll have to confirm that for you. I'm not sure.
Right.
Unless Tina knows.
But Carsten's probably got most up-to-date info there, I think. And I just wondered if there was a little bit more information you could give us on community bed provision, where Solent have made a decision that Jubilee House is to remain open despite the system wanting other arrangements.
I think this is around. This is just against this. Sorry,
I can pick up on that if it's for Karen. So Jackie, you'll be aware that our plan, collective plan across the CCG and the local authority and with Solent, is to consolidate our discharge to assess bedded capacity onto the Harry Sopnick site, so extending the opening of or increasing the number of beds opening on the South Sea unit from 20 to 40, and obviously utilising Spinnaker as well. And so we have a sort of a two-pronged approach around that and a more integrated and flexible model. And as you'll be aware, we have long had in the plans around the move of Jubilee House to off the Jubilee site because it's less than optimal for patients currently. It's quite an old unit. So that is our long-term plan. We were originally hoping to enact that plan from December. However, I think we felt that given the pressure in the Portsmouth and South East Hampshire system, we needed to extend that to the beginning of April. So we then looked at, and just to avoid any destabilisation really with staff and opening new units and moving units over the winter. So the plan was then to keep Jubilee in place until the beginning of April to open 30 beds, and so an additional 10 beds on the South Sea unit in advance of April, and to stabilise the permanent recruitment on the South Sea unit so it could increase its capability to take more patients. We are now, as given the pressures on the ambulance handovers as we've talked about earlier, we are actually now working with Portsmouth City Council to bring forward the opening of the South Sea unit to all 40 beds over the winter, subject to being able to successfully recruit, but they are out to recruitment for all 20 of those additional beds at the moment. And we're also looking and working with Solent to reopen another 10 beds on the other half of Jubilee House, which have been closed, and which, if you'll remember, we had to do last winter. So it is in our in extremis plan, again subject to staffing. Solent are looking to open additional 5 beds within the next week or so on that Jubilee site. Again, it's reflecting the shared risk that everybody is taking. We recognise it is not ideal, but it's a way of managing and mitigating the wider risk of ambulance handover delays. We're continuing to operate on the basis that Jubilee will close on the 31st of March, and then we will have the South Sea unit and Spinnaker fully fully operating by then, but obviously we've brought that plan forward too. Does that help, Jackie?
It does. It helps enormously. It just shows the volume of work and complexity of work that needs to go on, like you say, in extremis. But it's even more nice to hear that there's long-term, hopefully sustainable solutions, all based on recruitment as well.
Yeah.
And I'm not sure I've solved that one, but at least we'll have some capacity to put somebody in, some staff in.
Yeah, and the longer term is that Southsea is operated as a health and care model and site and close working between Solent and the City Council.
Good. Thank you very much.
Thank you, Carsten.
I just wanted to inquire again regarding the compulsory vaccination for care home staff. Are we sure that there's no risk to our care homes with staff suddenly having to depart by, is it March next year? Is this something?
November. It was the first.
I know that there was a first deadline, and then the rest have to be done. I think they have a while to go. But certainly, is this sort of now? Because I mean, where are all these staff? I mean, okay, that's not a question for now, but it's just to ensure that we're not suddenly left high and dry by homes being at risk of closure, of not having enough staff.
I think the short answer is I don't think we are at risk. I think it is minimal, as we've said, but I'll let Tina come in with the detail.
Okay, so there are two bits to that question, I think, Carsten. So the first bit, which is the care home staff only, and that came into force in this month, in November. So therefore, all of their staff are either have been double vaccinated, have an exemption, or have already gone. And the impact on our homes in the city has been almost negligible. None of our homes have had a problem. We are talking about 1 or 2 members of staff that had already departed long before the November deadline came in. The end of March, April deadline that I think you're alluding to is for all health and care staff. And we're currently working up what that means and the impact that has. Looking at our big trust, certainly so far they're reporting that they think that the impact will be very, very minimal. Already Solent are reporting something like 50 staff in total out of their, I don't know, 5,000 or 6,000 staff they've got. So, and not all of those are frontline. So I don't think we at this point are particularly worried about a major impact, but we're just working up what it means in terms of primary care and our acute trust. So we will report that in due course, but there is still time for that to be managed.
Lovely. I've got a question about the care home that's rated inadequate by CQC and where that's got to, because I'd heard about it a while ago and thought it all gone quiet and thought it might have gone away. There's obviously still an issue. So do we still have residents living in an inadequate care home? And if so, where are we at with that plan?
Do you want me to take that one as well? Karen, I can't look at you. Okay. Obviously care homes is the responsibility of the local authority. We do still have one care home that, as I say, this care has been inadequate. There's been a recent re-inspection by CQC, which I do not have the report of yet, but we are looking at a small number of people now, and they have been very carefully supported and assessed.
Thank you. So it's under control, if not sorted. Thank you very much. Any further questions or comments for Karen on this report? So we're being asked to note the contents. I think we've noted them well and commented suitably. Thank you very much. So now it's the Tina and Sarah show. Is that right? Have I got it right this time?
It is, Elizabeth.
On the safeguarding report. And Sarah, welcome to our board meeting.
Yeah, thank you very much for the invite. I haven't been along before. So obviously I won't go through the report. I assume you've all got it. It was just to say that we have changed it a lot since what we presented here in the past. We tried to focus it down more on what we were actually achieving as a CCG, as a safeguarding team. So if someone came in, they could see exactly the areas we've worked on. Obviously, it was an exceptionally challenging time, obviously, because we've had COVID. However, I think I'm quite proud, and you can actually see that we've achieved still quite a lot. Like I said, we changed it down. So what we've identified was key themes that we have worked on, what they were, our key achievements, and also the top priorities moving forward. So I think it made it easier to read, and it gives you an idea of what we are working on within the team, what we've done, and also the focus moving forward. Karen?
Mine wasn't a question, Sarah. Mine was really just, you take the breadth of this report. You fail to recognise how small your team is. You think when you read this report that you've got quite an extensive team, and I think that needs to be acknowledged, that you've done all of this with very few people, and that should be it's remarkable.
That's really kind, thank you. Yeah, for the majority of it, we did have a lot of change within the team, so it is in the report that we did move over, and I became like head of safeguarding. Obviously, Tina's role changed, and there was some vacancies. We've been really fortunate that Elizabeth joined us as part of our safeguarding team for the designated doctor role for LAC. But you are right, we are quite a small team, but we also work really well with our colleagues in local authority who have really helped and supported us and really made some good positive changes with us. And I think, as we move towards this ICS, we're doing a lot of work already in safeguarding across our designates, and without being smug, we are a step ahead in Portsmouth when it comes to working across multi-agency, especially with our local authority colleagues. So I've actually been asked to go over to the Isle of Wight and speak to them about how we've made such progress, especially with our looked after children team. So I don't know if anyone's got any questions about it. Oh, Tina, sorry.
Yeah, I just want to come in and say, Sarah, that I think you're really understating your role here, because we had about nearly a year, so most of this period of time with Sarah, and in a full-time role, and then our designated doctors who, in all fairness, I think, Elizabeth, we'd say, whilst you were all worked really, really hard, you were pulled back a lot into primary care, certainly through the pandemic. So I think Sarah's politely understating her role. So I just want to say well done.
Thank you.
Yes, and I was going to come in. My designated role is one session a week. Let's be honest, it's not much. We have a lot to thank Sarah's leadership for, and she gets the best out of us, I think. Good boss. I like the way this report's done. I think it's nice and trackable. You will be able to be benchmarked against it next year. So, you've set the bar high because your priorities are key. I think they're all great ones, but there's a lot of work for next year.
There is,
and I'm only around for some of it. So, any other comments or questions? Tina, did you want to come back in? No. Right. So we're being asked to note this report again. People happy with it?
Yeah.
Thank you. Right. And then moving on, we've got the Emergency Preparedness, Resilience and Response annual report. Jo, are you doing this?
Yeah, and again, this is an annual report. Probably takes on increased significance over this last year, or year 18 months. But again, just just shows the work that we do in terms of emergency preparedness and response, the work that's done at partnership with the local authority and with the ICS in Portsmouth, South East Hampshire. And again, as we head into winter and as we recognise that could be difficult, and the work we're doing as partners to resolve the ambulance handover, again, those processes, although we're not in major incident, in being able to enact and work in partnership in line with those processes that we do when we are in a major incident, and as we have been for some of the last year, that it just shows how important they are really, and how it helps us come together and really focus on the most important issues. So I think that was the bit I wanted to bring out mostly, really.
So any comments or questions? I have to say it's another impressive report, and it this field of work has always been sort of, it's one of those things we've had to do, and I've been in the NHS for years and we've never needed it. Oh yes, as you say, boy have we needed it. And I think it's the strength of the relationships we've had. It's been easier locally than in many areas, so it's all credit to everyone who's worked on this agenda for a long time, that the relationships are there and everything's stood up. So are we happy to note this report with grateful thanks to the team for doing it? Lovely, thank you. We're then moving on to minutes of the other meetings. So we've got Primary Care Commissioning Committee, Health and Wellbeing Board, Audit Committee. Do people have any comments or questions about any of these? Stunned silence. Is that a case of we are happy to note those all? Lovely, thank you. Which brings us to the close of the meeting. Well, we caught up. That's impressive.
You finished early.
So we've got next Governing Board meeting to be held in public will be on Wednesday the 19th of January at 2 p.m. till 5, and streams online via Teams again. At which point I would like to once again thank Nick, as this is his last board meeting. Thank you very much for all your hard work over the last, I'm not sure how many years, 5 years? You will be sorely, oh, is that all? No, you'll be sorely missed, and I've really valued your input, particularly in the mental health arena and more latterly in the primary care work stream. So thank you very much, Nick, and we wish you all the best moving into Health Education England. Thank you very much.
Thank you.
At this point, I would like you to end the streaming, please.
Okay, just bear with me. I'll just go and turn it off.